Hello, everybody. Welcome to this EMCC Global GPS Dialogue. Really delighted to have Dr. Andrew Parsons with us here today. Andrew's from the EMCC UK Health and Wellbeing Special Interest Group. And I'm really excited to welcome Andrew here today. He's going to also be giving us an update on his work at the Fountain Centre, where he's applying a coaching coaching approach for people with a cancer diagnosis. So this is going to be a fantastic hour session. I'm really excited about it. And without any further ado, I'm going to hand you straight over to Andrew.
Thanks very much, Nicola. Real great pleasure to be here today with everyone. Just sharing some of our thoughts from all my sort of experiences, really, particularly around research practice and from my background in the pharmaceutical industry, where I was involved in business units sort of delivering research and development clinical trials to a wider organisation, and just thinking about that orientation and how we can apply that into the work that we do as coaches and mentors and building that evidence base. So it's a real pleasure to be here. It'd be interesting if does anybody work in a health and wellbeing space or a clinical space? Maybe if you just pop that in the chat. And where you're from, just say hello. It's really wonderful to see everyone. So it's interesting. Health research, this is kind of an interesting area for us, isn't it, in terms of how do we sort of bring these new processes, new techniques into supporting people who may be in care. Yep, thank you, Carmen. Psychotherapy, nursing experience, and hello, everyone from all over the world. It's just wonderful to sort of be here on the Greenwich Meridian, actually, because I think we just have access to everybody. So that helps, actually. That gives us an orientation, because I think there's been so much wonderful work done from a clinical perspective and also from psychotherapeutic perspectives around building that evidence base for people. And it's really sort of what can we learn from that from a coaching perspective. So this is the topics for discussion that I thought would be sort of really good for us to sort of run by today. So it's just an opportunity just to reflect on the differences between efficacy and effectiveness, and how can we bring that into practice? How do we assess them from a clinical trial perspective? And then maybe bringing these some considerations into the delivery of a coaching service. What's important for us to sort of bring them into how we operate. And I know the psychotherapeutic world has sort of been working with these questions for some time now, but do we match clients to practitioners? Do we match different processes or orientations to the practitioner? How is the best way for us to do this and build some evidence base? What about the role of individual coaches and their scoping practice? That might be some area to think about. And also, I do get the sense there's quite a large conversation around the overlap between coaching and other talking processes. And actually, many of us may have a whole host of different experiences and different trainings. And just thinking about what's our scope of practice and how that might sort of fit into building and understanding these differences between efficacy and effectiveness. Considerations of dose. How do we manage the dose of coaching, and what is that anyway? How do we really understand that coaching dose? And then working with cultural and social demographic differences. And I think this is a rather interesting one from an evidence base, because many processes may be developed within a certain narrow band of individuals. How to widen that out to actually access people from different cultural backgrounds or different ethnic backgrounds or different social demographic experiences. Is that top down? Do we manage the process for that culture, or do we have to redevelop our evidence base for each of these individual cultures? Maybe just some things to think about. In my old world, these really were the hierarchies of the evidence base that we used to be to consider. Our job really in the pharmaceutical industry was to sort of develop evidence through randomized clinical trials. And my role usually went into early stage clinical trials where we were getting our hints or proof of concepts and efficacy and setting the scene for larger trials where the clinical effectiveness would be sort of really established. And then there's a whole process post-registration that is very, very important to the development of that evidence base and understanding how new medicines are really worked in the clinical armory. So, the ability to hold, systematic reviews and analysis of several randomized trials then is really at the top of that hierarchy from an efficacy perspective. And it's all about that reproducibility, transparency, and generalizability that becomes really important. And just how do we do that in our coaching research and our coaching practice? How do we make our processes reproducible, transferable, generalizable, and how do we build evidence around that? So just from a lean management informed view, this is the way I sort of think about things in many ways. So an IPO is what we used to call these things. So it's an input, we have a process, and there's outputs that we may measure. So input is usually around the rules, if I can call it that, of the process. So whether it be CBT or humanistic psychotherapy, whether it would be, who do we administer this medicine to? There's usually some sort of rules-based approach, which allows us to get consistency of how people are being entering a process. And there may be different orientations around that. So there may be different coaching styles, different coaching systems, or different coaching practices that would feature as part of that input. And then there's practitioner elements of the process. There are client elements of the process to consider. And then how do we measure output? Often, I think in the coaching world, we're really considering behavioural outcomes. But actually, there are physiological, there may be cognitive outcomes as well. We may think about things very differently, following a coaching process, but our behaviours may not really change. But actually, the intention of that behaviour may have a whole different scope. And I just put that out there now, just to think about, the impact of a clinical diagnosis or a life event that is, somewhat transformative. Your behaviours may well change, may stay the same, but actually how I see the world, the cognitive differences may actually be really important areas for coaching. And I'd like to come back to that as we just share some of the updates from working in the oncology service at the Fountain Centre. From a healthcare or a healthcare service perspective, the economic value, economic outcomes are perhaps even more important than the behavioural. How do we sort of really build that into our practice? So these are the main considerations, from a development point of view, if we're sort of developing a new medicine. Effect, clinical effect, safety, paramount in terms of how do we develop a safe and effective intervention. But it's also really important to think about that generalizability. And I just bring that in now, actually, because thinking about how we apply our coaching processes or our coaching inputs, having that thought at the outset around how do we sort of really build that into a generalizable and effective system that's really working and for as many people as possible. Actually, that really needs to be part of the design. And in this process, we used to spend a lot of time trying to build, work with a whole variety of different trade-offs around quality and cost, efficiencies and effectiveness. Because you could have a really efficient system that may not have much ability to adapt or limit the agility to respond to events that may occur outside of the process, which would limit its effectiveness. So I've worked in many groups where actually the processes that we use were very efficient, but they may not have been very effective for our customers. So there's a balance there that we need to have. And really, it'd be great to get your thoughts and views on this and the differences and similarities between efficacy, it's not quite efficiency, but efficacy and effectiveness. And Nicola, this would be our opportunity just to put everybody in pairs, really, just for a brief conversation. around what do these things mean for you, and how do they impact our research, our practice in coaching. Thanks. And I'd just be really interested if people just want to shout out or put your hand up. What differences, similarities between efficacy and effectiveness? What are they for you? Or the chat? Whatever's good.
I'm happy to contribute.
Yeah, thank you.
From a coaching perspective, I know the term efficacy in relation to self-efficacy.
Yep. And
effectiveness more as like from language, from speaking, you ask how effective was it?
Yeah.
So it seems more about effectiveness, seems more to me about measuring something, being self-reflective in the coaching space. You know, how well was this done? What have we achieved? Was it effective? Did we achieve? And self-efficacy has more to do with the ability to do something.
It's an agency, isn't it? It's
efficacy is more about a sense of agency and effectiveness. So although they, in terms of how you spell these two terms, they seem very related, and they maybe are related in process in terms of you want to have great self-efficacy or efficacy to be effective, but actually there's a big gap actually still between them, because effectiveness is maybe more like how is it, and efficacy is are we able to do something
about it. Yeah, brilliant, thank you. Yeah, really powerful. And some thoughts on the chat there as well, just to add. So thank you, Sharifa. For coaching to be efficacious, the client must have an internal locus of control. It's that agency thing again, isn't it? Efficacy can be measured, but it's much more as reflective, as Dorian said. Yes, thank you. Thanks, Nick. And Esther's efficacy integrates effectiveness, but is bigger, including visionary, meaning, focused on the client's EQ and growth. And really what we're really about, aren't we, in terms of our coaching practice, is enabling that efficacy, that agency in others. So it's a really interesting sort of way in which we sort of think about these things, and they have different meanings in different contexts.
I see Jeremy's hand up. I see you just put it back down again, Jeremy, but did you want to come in?
So I was looking at it. Thank you, Nicola.
Thank you. I'm not entirely sure that what I've got to add is going to add too much to what has already been said, but if a very simple distinction between efficiency, if I can use that word rather than efficacy, and effectiveness, is that efficiency relates to process and effectiveness relates to people. And that for me is a distinction that I gained something from. Well, I think it raises quite a few questions in itself, but that's what went through my head as you were talking.
Thanks, Jeremy. Yeah, it's interesting, isn't it? So the efficiency bit is more of what is done and how it is done, and the effectiveness, how it lands. So it's a customer process, isn't it? Effectiveness is how is this received with benefits. You know, I guess just that's what was coming up for me as you were talking as well. Other thoughts? Any other hands?
So I'll come in. I'm surprised that efficiency came in, because the two that you spoke about, efficacy and effectiveness. So let me get back to those original ones. As Viviana said, effectiveness is about looking at the outcomes or the results. How effective were you? You could be very efficient or very efficacious, but you aren't necessarily effective because you haven't necessarily focused on the outcome that you want to achieve. So you asked about similarities and differences. So that's the one that Viviana and I came up with. And the efficacious has to do with the manner in which we reach the outcome.
Brilliant, thank you. And wonderful, thank you everybody for contributing. I just want to offer a slightly different perspective around how these relate to the building of that evidence base. Because actually building that evidence base is so important for us to bring recognition to our profession as coaches and mentors. So I think absolutely everything that's been said so far, I think is agree with it all, actually. I just want to add something, which is from the perspective of building an evidence base. Efficacy is kind of that wayfinder. It's actually, how do we create something that is reproducible and can be sort of scaled, and has that approach where you get that consistency and safety. The effectiveness is how that works in real life and real practice.
So can I ask you a question, Andrew?
Please do.
In research language, we would say validity and reliability, right?
Yeah.
So which one are you relating to validity and which one are you relating to reliability?
It's both on both.
I thought so. Okay, thank you.
Because the validity of what we do is, it has to be real, I guess. And I'm sorry, Jackie, what was the second one again? Got mine, like I said, validity and
reliability.
Reliability. I was going to say reproducibility. It's a reliable measure, isn't it? So, and you can make that measure several times, and you'll get the roughly the same data, if I'm understanding you correctly.
Thank you.
Both of those apply to finding the process that works and understanding whether that process is effective in the widest possible population. So let me just go back to the slides again. Evidence-based practice is often around an efficacious approach. So it's around understanding what we do and getting that reproducibility and the validity, the reliability of what we're doing, but around a process. And in the clinical development world, this is often thought of as a treatment. So it's something that you do, and you do reliably, and you build that evidence around that process, that input. So it's more input focus in my world. Practice-based evidence may be more output related. Because is this practice or this service that we're running actually effective for the people that are using it? And I'll go on to this in a little bit more detail, particularly about the work that we do in the Fountain Centre, because I think the Fountain Centre really features within this practice-based evidence domain, perhaps more so than evidence-based practice, because actually we were doing different processes were used by different coaches. Any questions on that just before we move on? Does that make sense? It's perhaps a different way of thinking about it. But is a clinical framework really appropriate? Particularly if we're working in a health and well-being space, there's sort of two ways to approach, the health and well-being area. One would be a medical paradigm, with evidence-based practice is the cornerstone of everything that is done from this area, and from a medical paradigm, it perhaps has that professional expertise, but from a wellness paradigm, it's kind of more individualistic. So the medical paradigm is around the population. The wellness paradigm is perhaps more individual, it's more holistic, it's more systemic, but both have a role to play in the support of the individual's health, from individual and perhaps even from environmental determinants as well. Just to bring this into sort of some sort of context, interestingly, I found out I was dyslexic not so long ago, and actually that made a lot of the patterns in my life kind of stand out for me. But just digging into the whole neurodiversity world with a little bit more interest, it's kind of interesting to notice that actually ADHD and autism are considered a clinical condition, whereas dyslexia is not. It's just something that you live with. And so there may be different ways to think about how we operate in providing that appropriate framework. There's a number of factors that may predict the impact of the psychotherapeutic process. It's not just the patient and the therapist, but it's actually the individual process that's used, but also the context, because things may happen outside of that context, which can impact the outcome measures. So those are the outputs, which often we're thinking of them as being behavioural, but again, they could be physiological, they could be economic, they could be all sorts of different things. But these are the factors that we perhaps need to consider from that efficacious and from that effectiveness perspective in building that evidence base. So some things are thinking about efficacy. So it's the process and the role and the rules in creating an evidence base. Is one process more effective than another? What are the inclusion-exclusion criteria for people entering the process? What do we do with protocol deviations? So if we do have a process that we've built an evidence base around, how do we know that we're holding to that process? How do we make any adjustments to it that still lie within the protocol and don't differ too much from the protocol? And just bringing in that, so how do you bring these processes into different multicultural contexts? Just an interesting maybe way to think about it. How many sessions are required to build that evidence base from an efficacious perspective? Often within a psychotherapeutic framework, there'll be a very structured discussion or intervention, maybe weekly at the same time, same point. That might be different in coaching. We may have a month or so between more. So what's an effective dose? How do we really measure the impact of the number of sessions that people are taking? Does the same session have the same relevance at the start, at the end of a coaching session? Maybe things to think about how we build our evidence base. Practitioner expertise, again, from a psychotherapeutic orientation, supervision, a learning and a development orientation within the therapist are really powerful tools or predictors of outcome. Scope of practice, the context of the service. These may be all things to think about around developing that process or those rules-based interventions. The whole range of multicultural and social competencies that the practitioner will need to be able to sort of use in their work. There could be client factors as well, different context. For working in organizations, the organizational culture will have an impact on how we build that efficacy measure. And how do we use, what is it we're measuring? Are we using validated measures? Clinically, psychotherapeutically, PHQ-9 and GAD-7 are often used. How do we do that with validated measures in coaching? Will we use more client-reported outcomes? And then think about what do we do with missing data? These are all areas that impact the effectiveness of any sort of trial or evidence-based intervention. And interestingly, perhaps one of the big ones we need to think about is what do we compare it against in terms of our efficacy? And I'll just pause there for a moment. Any questions, anything in the chat that might be coming up for you?
By depth, I mean somebody has an insight that is so strong that it changes his or her entire life.
Yeah.
And it's like a key to a major trauma or a major insight into what to do next. Whereas quantity might be lots of small little insights that are more superficial. So one thing for the coach, maybe lots of insights may sound better because there are lots of little results that the person gets. But for the client, a really profound, deep insight may be more moving. So how do you measure which one is, let me use the word better, because I don't know if it is more efficient or efficient.
Yeah, totally. I think it's a real issue in the work we do, isn't it? It's how do we assess that? And just thinking about how do we sort of create an evidence base around that difference that may happen. And I've got some examples that may help there, Esther, but please do come back to me if this it doesn't get answered. Any other thoughts on that from people? It's great point.
I've got one actually.
Yep.
From what Esther was saying, is around depth and about how do you know how deep is possible if you haven't experienced really, really deep insight and reflection before. How do you know to what depths you're able to get? We all think that I don't know, so we all think, I would assume that we think we know what depth looks like, but we might not.
We might not. And of course, it'd be very different for different people at different stages of their lives.
I think that's a very interesting point, Nicola, is is what does that mean, a deep insight, as opposed to what might be a smaller insight? I don't see how that can be measured or determined or defined, being as each situation is very unique and individual.
Yeah. Brilliant. I have a suggestion, which I'll come to shortly. And thank you, Jeremy. Coming from a research background and as a coach, it's all a bit daunting, isn't it, to apply these efficacy-based, evidence-based approaches to the coaching process. And that's kind of an interesting sort of tension I'm hearing there for you. Again, maybe just inviting people to think about practice-based evidence as a different approach to creating that evidence base. Nathalie, which of the three is like quantum analysis with covariates line, a linear regression or an ANOVA? Coaching is not expressed quantitatively. It can be, and in the eyes of those who may be looking for developing an evidence base or a return on investment, often it is, I guess. And I agree with you. It's a very humanistic thing. It's an individual thing that we work together with people, and it's reciprocal, isn't it? It's very interesting. How life-changing are the insights? How do you assess that? Super. Let me hold those questions, and I've got some opportunities to think about how we build that evidence base from the work that we've done. Just to add another layer of complexity, if you like, in terms of efficacy-based studies, which I'm thinking about actually controlling the inputs, about how we work. In the clinical setting, these were some of the evidence perspectives that were sort of brought for using systematic reviews. So generalizable populations in primary care, so that comes into who's coming into the coaching process, the outcomes you'll use. But this intention to treat analysis becomes rather interesting as well, because actually, from that evidence-based perspective, what people are really looking for is the intention to treat. So that's everybody who's enrolled in the trial is your baseline comparator. The other way of looking at it is per protocol. So per protocol is the people who complete the trial condition within with minimal deviations. And the reason that people do this is because what they're looking for is to assess the effectiveness of that intervention in a more generalizable population. And again, this doesn't really land very well with me thinking about how to create that evidence base from these efficacy studies as a coach. But perhaps there are different ways in which we can start to think about this. Because even within the clinical world now, there's a stronger advent, or a stronger push nowadays for learning in the real world. And I just use this as something that I thought was just really interesting when I came across this. So this is a publication that's actually come from the Federal Drug Administration. So this is the body in the US that registers new medicines and regulates the use of them. And it's kind of just an interesting sort of perspective because, in the olden days, development of medical treatments was based on real world experience. It was practice-based evidence that came into the fore. And there's some fantastic treatments that are still available today. But in the last 100 years or so, there's been the use of randomized clinical designs for drug trials. And that was based on the worry or the concern that anecdotal evidence weren't giving the full picture. And this has become the mainstay now, really, because actually that evidence-based generation is perhaps, if it doesn't fit to this evidence-based world of efficacy studies, perhaps the evidence is a little bit doubted. But actually, you can't do some of these trials in certain clinical populations. I used to work with rare diseases, and actually, it's just impossible to do randomized clinical trials in some of those populations. So what's been happening recently in terms of evidence-based generation is actually the use of real-world data and real-world evidence. And in terms of the FDA, real-world data is just data relating to the patient's health status, or the delivery of care, perhaps from a whole variety of different sources, and they're using real-world evidence as the clinical usage or the usage of that medicine. And perhaps this is another way we can think about generating an evidence base in coaching. And again, just some considerations. Again, this is from the people who regulate evidence-based processes for medications in the US. These are the randomized studies, or the interventional study, may use these real-world designs and plannings. But actually nowadays, outcome measures are really moving into digital health technologies. So health records and outcomes are becoming, these economic measures of outputs becoming more relevant. And actually, you can use non-randomized studies now, which can actually support the development of evidence, like using an external or disease history group, or a case control crossover study. These are becoming much more powerful in the realms of the FDA in creating that evidence base for the processes that they're using. And I'd just like to ask you to hold those thoughts, just to sort of use and explore some of these considerations in the development of the coaching service at the Fountain Centre. So the Fountain Centre is an independent charity that offers emotional support work for it's a regional hospital in the NHS in the UK, but for everybody going through the cancer care treatment in the hospital. And it's kind of interesting from a medical perspective. These are the top 10 cancer concerns that came from the electronic health needs assessment that came from Macmillan. And we took this data about 2-3 years ago now. But you can see the whole list of things that sort of impact people through their cancer treatment. So how do we sort of think about this from the client experience? So this is, again, just showing some ways of maybe thinking about practice-based evidence. So we get referrals, may have walk-ins to the centre, but then there's an active process of assessment with a health practitioner, and they assess perhaps the process that's most appropriate for that individual. So we're not taking all comers, we're actually matching the client to a practitioner and a process. The service delivers counselling, coaching, complementary therapies. There may be other support that's necessary. It could just be information. Citizens' advice, for example, would be a really great way for people to understand their legal situation once they've had these impact. So there's an active matching of people through their experience of working at the centre. And following completion of that process, there's actually a review, and they may sort of re-enter or carry on or be signposted to somewhere else in the process. So very much this is kind of that real world based evidence approach, where we're not managing the clients coming in, taking all comers or the inputs. We're really focused on the output of what we're looking at here. There was also an element of matching for the practitioner and also the process. Because actually, we take this from Professor Sarah Corrie in terms of where does coaching fit in mental health support. There's often in coaching, we work with people who have got high function, high resources. It's that place of going from good to even better, or good to great. We would not work with somebody who's really struggling, so the low function, low resources. But in the centre, coaching actually works quite powerfully with people who may be, managing the situation. From a clinical perspective, they're managing. So they might have good function, but actually, they're not. They've got low resources. They're not getting to that place of sort of thriving or flourishing, or that place of empowerment. In the top right corner there. We may also be working with people who are perhaps sort of just hanging on, so they're sort of getting along, the functioning, but may have low function, but they're using all the resources, so they're managing the situation in a way that it is allowing them to be the best they can be at that time. And then where does coaching fit? And of course the ability of the practitioner to work in these areas really matches their scope of practice. So the coaching process, just thinking about and going back to Esther's view here. So 6 1-hour sessions, review after 3. Possibility to extend or terminate. In the process, what was really important for us was an alignment on the definition of coaching. And I think this comes into, what is evidence, Esther, in coaching? So it's the ability for people to change the way they think, the way they feel. They may have an opportunity to develop interests or different meanings. All these things would count as an evidence-based approach for people reviewing and assessing the impact of that service. We work within the quality assurance of the hospital, so the hospital governance and professional frameworks of the individual coaches. But because we were output focused, we actually worked with a whole range of coaches from different styles and different backgrounds who have a different scope of practice. So we work with medical coaches, psychosynthesis coaches, even coaching psychologists, and that range of experience and backgrounds allowed the service to match the individual practitioner in a way that was able to sort of be the best for the practitioner and for the client. A lot of different backgrounds, nursing business, perhaps some complementary therapy work, but all the coaches who volunteered there had an interest in mind, body and spiritual work. And we really heightened the importance of supervision in that space. And dose is kind of an interesting one for us to think about here, because is it the number of sessions, or I think what Esther we were getting at to before was that the intensity of the learning or the transformational nature of that learning. What determines completion of a session as well is kind of interesting, because I think our practice would suggest that perhaps the sessions are more regular at the start of the coaching process. We may often have a long tail to complete, and by that, actually, we may work with somebody for 6 months or longer, and 3 or 4 of those sessions may happen in the first few months, but actually we would always would consider holding a pause to have a session booked, for 3 to even 6 months hence the initial coaching call, because actually people requested that. So from determining that evidence base, what is the dose? And is it important to complete all sessions, or is it, the impact can happen after just a few?
So I can't put my camera on, but I just love what you put in the first slide, is this sort of evidence-based management approach. And I know Rob Reiner is an advocate for that. He tries to do it in human resources, and not only tries. And the link is just an image, like one of those infographics that shows the process alongside of what you've described of what organizations can do internally, which really coincides quite nicely with what you're presenting here.
Oh, thank you. Yeah, I'll have a look at that. It's really, really interesting. Because I think sometimes we can get stuck into what are the rules of what we're engaging with, rather than how do we make it really effective for the people using the service. And actually, when we looked at this a few years ago, the presenting themes were really interesting as well. And again, Esther, I think this comes back to evidence. That these were the themes that people were presenting with. There were, emotional issues, perhaps not surprising from the output from the electronic health needs assessment. But interestingly, and none of this was related to the medical condition. This was just us as humans, just managing what was going on and finding ways to cope with the situation in which we're finding ourselves in. Confidence often gets knocked in these situations because the world's changed. The world's no longer different. What used to be is no longer. How do we build confidence to build back into our world? Adapting and coping strategies, a common theme in the coaching work that we do, and actually changing relationships with family and other relationships, perhaps importantly at work as well, when people are coming back into the workplace from these medical diagnoses. So all these were presenting themes. And actually just using that as a consideration for what are the best outcomes that we can measure might be sort of an interesting thing for us to think about as well. Because there may be some behavioural outcomes here, but the behavioural outcomes will be very different for different individuals. The other really important element to think about from that process issue around the practitioner is multicultural competencies. And I know there's been a lot of work that's been done in this in the psychotherapeutic area. And again, this also works in the coaching service in which we were operating, because we were working with anybody who came into the service, anybody who walked in. So there was a whole range of multicultural variables that we perhaps needed to be able to consider and meet the client where they were. So, you know, that ability and agility to sort of be totally present, you know, those coaching skills just really stand out as being one of the most important areas that we needed to sort of build through our supervision practice. So in process measures and outcomes, how did we know this, you know, the evidence for this? And again, and I think feedback is really powerful here. So this was feedback that the service received from somebody using the service, actually during the times of the pandemic. You know, a huge impact in that person's life. You know, how many sessions did we have? It probably doesn't really matter. When was that impact made? Well, do we really ever know? But actually, this person was very, you know, something had transformed for her. There was a transformational learning step through this process. And in the early days, this real world data was how we sort of really developed the service. Because, you know, the people in the hospital would say, well, actually, if people come back to use the service, that means it's really useful, because often people wouldn't want to come back into the place where they were treated. You know, that element of agency that had been developed within the clients, very, very powerful evidence and very powerful impact assessment. And also just receiving positive feedback from clients, the centre staff and other healthcare professionals, really powerful. Again, that builds that real world data and that real world evidence. We were using in-process measures. So these would be client or self-reported outcomes, because this provides the opportunity for the client and the practitioner to build their evidence for change, but always able to change. So these were not really outcome measures. These were more the lead measures of where we were approaching the outcome that the client was looking for. Outcomes, I'll come on to this in a minute, but I'm very happy to share some of the data that's just been presented at the Health and Wellbeing Special Interest Group from Andrew Marin at the University of Portsmouth, who came in and made an independent review of the service. Perhaps from an evidence base, from an NHS perspective, you know, validated independent outcome measures would be sort of really powerful. Perhaps if they're independent of the coaching goals, even more powerful, because, you know, we're setting out to reach these goals and we meet them. Is that really an outcome, or is that a measure of the process? Perhaps non-clinical goals, perhaps economic benefits could be assessed as well, you know, in providing this evidence around this practice-based research. And just a comment there from Esther, I think. I've just missed it. Healing for the patient immediately versus over a long time. What does coaching say about the parallel to coaching? Yeah, I think it's a really good point, Esther. So in medicine, you're treating. I think what we're doing here in this coaching process is enabling people to develop. So I think it's a very different perspective, and I'm very doubtful that the clinical way of thinking about building an evidence base around coaching is going to be the most powerful one that we can build. And there was a comment there from Jackie as well. How can we use neuroscience findings here? I struggle with the issue with culture, as there seems to be a lot said but little known that challenges the status quo and treats people as individuals. Absolutely. Able to change is a difficult concept to sustain when certain things have become part of the normal descriptors. Yep, absolutely. Totally agree, Jackie. And I think it's that self-acknowledgement and self-awareness that can create that transformational change. And often that requires a lot of practice on the part of the person making the change. And I think as coaches and coach practitioners, we can really help people sort of develop that practice, you know, to create that change. Could you say what type of processes measures was used during? Yes, absolutely. So in the process measures, we used two really. One was MyCore, which is My Concerns and Wellbeing Score, which has been used extensively in complementary healthcare for assessing change due to complementary support. we changed that a little, just made a self-reported outcome on a scale of 0 to 10 with 3 issues that the client wanted to explore. It was as simple as that. It was just a self-reported measure. The reason we changed was some of our practitioners found it kind of a little bit tricky to have that conversation about, well, what are your real issues here? Which again is that treatment perspective, that treatment paradigm, and then focus on, well, actually, let's move towards the solutions. So we actually just changed it around a little bit for the in-process measures, just to be focused more on what is it you want to get out of the coaching, and where are you on that. I hope that helps, Dorian, there. So these were the findings that Andrew very graciously sort of said we could share here today. So these were the overarching findings he found from the clients. And again, in terms of building the evidence, how this is going to be measured, I think it would be very interesting to see how the university and Andrew sort of continues his research. But coaching supports the clients to regain control in their lives, raise awareness. It's that empower self-growth and renegotiation of self. So how does self change in this process of these events? May not be so behavioral, might be more cognitive or something else that's happening there for those individuals. Clients are highly anxious and overwhelmed, in this condition. The practitioners work with that client knowledge and that creating that space of personal development to create that transformation or that transition and self-discovery of the client. So it's very much a personal development approach. And just re-establishing that sense of calm in the people that were using the services. And again, I think was very pleased to see that all our coaches were using perhaps the processes that they were most familiar with, but very much tailored to the needs or the requirements of the moment in terms of the work. As a service, it's really creating that safe and therapeutic space, working with them on that unique level, really focusing on that wellness paradigm and working holistically with people. It was really interesting to see that from his findings. So thank you very much for being part of this discussion today. Hopefully it's provided an opportunity to just reflect on evidence and as generated by efficacy and effectiveness studies, to precipitate behavioural change and others. What we've been able to do really is just thinking about, the IPO, the input process output, to think about the differences between creating evidence with efficacy and effectiveness studies, clinical trials, may be one way in which we can think about building an evidence base for coaching. It may not fit all coaching interventions, and the cancer coaching service in Surrey certainly has provided some practice-based research. Some methods, validated clinical outcomes, but actually using real-world evidence and real-world data, I think perhaps is the really interesting way forward for us to go. And just considerations around evidence is, how do we match the requirements of the work, so the client and the practitioner, and the coaching process that they're familiar with and can use. The scope of practice then of the practitioner becomes really important, and also considerations of dose. So I think the average number of sessions used by people in the service, I think when we looked at this a few years ago, was somewhere between 3 and 4. So, some people use the service more, some people less, but there were changes happened probably quite early on. And how do we really work with those cultural and social demographic differences, particularly in terms of how to flex our own understanding, as practitioners, to be really truly present with them. And thank you very much for your discussion. It'd be really interesting if any questions, any takeaways to share from today's call.
A couple of comments in the chat here as well. We'll go back a bit. Patricia was talking about family work to help them support their loved one in the team as well.
Yeah.
Jackie's reflected that coaching reawakens aspects of the brain that remain unused for some time.
Yeah.
And
yeah, thank you.
And Agnieszka is wondering about how to approach the side effects of the coaching process, positive and negative.
Yeah. how to define them.
Yeah, there's a lot of questions for reflection there.
And that actually, with the work relationships, there's a consequence for people thinking about their relationships and how they change. And, it's really interesting to think about that as well. So it's a real system change.
Thank you, Andrew. I know we're at time now, but we've got a half an hour of networking. So I'd say hold those questions because we could have a chat with those in the networking as well. But can I extend an EMCC thank you to Andrew for leading this discussion today, and to all of you for adding in so many good reflections and asking so many questions and bringing in so many points as well so that we can all learn together. So thank you to all of you.
Thank you, everyone.